Okay, let's go ahead and get started. Thank you, Josh. Excited to hear about this fever that we can't sweat out.
Yeah. Thank you all for being here. I'm Josh. I'm one of the first year fellows if we haven't met. I'm sure more people will trickle in, but this is kind of a longer case, so I will just get started. So we'll start with some history. This is a 56-year-old guy who initially presented to an outside hospital with perforated appendicitis, got an appendectomy in early this year in January. He then was admitted basically every month since April for abdominal pain, weight loss, and importantly, intermittent hematochezia. His outside hospital imaging showed that he had distal ileal enhancement, and they thought that he had Crohn's disease because of this. Although he had a negative EGD colonoscopy sometime earlier in the year, which we don't have reports of, and had a negative calprotectin, they tried steroids many times. Unclear exactly what the response was. He had a colonoscopy that we can see in June of 2020, June 15th of 2025, that went 5 centimeters into his TI and reportedly was normal. He then went to another outside hospital admission in July with hematochezia. They gave him infliximab then, thinking that he had Crohn's disease, and they wanted to transfer him to Stanford to get a lower double balloon to try to see if he had any other lesions to confirm the diagnosis of Crohn's disease. He was ultimately unable to be transferred, so then he eventually just left and then came to Stanford to this hospital admission. So when he presents, he has a fever of 101. He's tachycardic to the low 100s, has some abdominal tenderness. His history is otherwise notable for an atrial myxoma that he has excised. He works as a cook and then otherwise doesn't have any drugs or alcohol that he uses. He's a former smoker. He had a calprotectin of 11, and then just highlighting some of his imaging in red, you can see he had this distal ileal enhancement with fat striatum, multiple lymph nodes, and MRI that kind of showed the same in his right lower quadrant with some areas of luminal narrowing, and then a CT in July again showing the mesenteric lymph nodes and thickening of his ileum. He had the colonoscopy that was overall normal, just with some mild diverticulosis. So then he comes here, and we have Ian and Ashley who scope him on the 23rd, who in his TI he had two large ulcers with no bleeding. They biopsied it. They also took out a sessile polyp. Otherwise, it was normal, and his TI biopsy showed ulceration with granulation tissue, acute and chronic inflammation, and then no granulomas, and negative for CMV and AFP. Going forward, he has his first chapter of his hospitalization, which is bleeding. So he has an RT called on 720 for hypotension, hematochezia. They got a CTA. It showed active extravasation in his ileum. And then he was upgraded to the ICU. He had IR embolization of his ileal branches. Interestingly, he had an MRE earlier, like a couple hours earlier, that the next day showed that he had active extravasation from his ileum, though wasn't clinically useful at the time. I just thought it was interesting. He continues to bleed on the 30th, about a week or so later. He was redosed with infliximab because he was bleeding. We had a presumptive diagnosis of Crohn's disease, and we thought that he should continue on the pathway that he was currently getting. That was on his last day in the ICU, and then he downgraded to the floor the next day, although continued to have bloody ostomy output. So he was rescoped. We did an EGD this time, which had some erythematous mucosa in the antrum, but otherwise was normal. And then he had a colonoscopy that 20 centimeters from the ileocecal valve, he had a 15 millimeter ulcer, which wasn't bleeding, but 3 clips were placed, and then we tattooed proximally to it just in case he bled again, because at that point it was thought that he would need an ileocecectomy because he's bled several times before. And kudos to Elsie and Andrew for doing this one. He, a couple days later, has another rapid response where he has 3 large bloody bowel movements. He's tachycardic, he's hypotensive, his lactate's 6. They get colorectal to come, which per the note seems like they just came to the bedside and overall thought that he would benefit from an ileocecectomy. So they took him to the OR. They actually found that his ileum was perforated, which you can see in the middle picture there, and it was walled off, and he had multiple ulcers proximal to the tattoo. Another one which which appeared to be near perforated. They saved the last few centimeters of his ileum so they could preserve the ileocecal valve, and in total took out 115 centimeters of small bowel with 300 remaining. At that point, they thought that surgically all the remaining small bowel looked okay. The path from this showed small bowel with patchy ulceration, transmural inflammation, and with viable margins. He continues to bleed. At this point, he has an ileostomy, and Rishi and David scope him again. They saw a 2 centimeter long circumferential ulcer with adherent clot, 10 centimeters proximal to the stoma, again with path showing chronic active ileitis with neutrophils, no granulation tissue, no granulomas. Overall thought could be compatible with IBD in the right context. So I'll hand it over briefly to Grant. Grant was our inpatient attending on Wednesdays, trying to help us through this difficult case, and we kept talking to the medicine team about is this typical for Crohn's bleeding or not? And overall, we thought not. Grant?
Yeah, absolutely. So I was involved in this case fairly early on, and as many of you know, I go in every Wednesday. I was able to see longitudinally where this was going, and even early on, I was very concerned that we were dealing with something that was not IBD. This is recurrent bleeding is an unusual presentation for Crohn's disease, including life-threatening bleeding. And then after he undergoes ileocecal and all active diseases removed that they're able to see, he then bleeds again after that. And we scope him, and indeed, there are more ulcerations proximal. So I think it's pretty unlikely that those were missed by the surgeons. So to me, it seemed like there is new disease coming up very quickly after his surgery. That combined with the atypical presentation really had me saying we need to broaden our evaluation. Even though the pathology is showing acute and chronic inflammation, this isn't lining up, and we need to change our approach and look for something else.
Thanks so much. So what I learned from Grant is that life-threatening bleeding in Crohn's disease is overall quite rare, and it's also atypical for these ulcers to recur so quickly because this is a subacute chronic process. The next part of his hospitalization was really around his fevers. So we can see his CRP trend here and his fever trend here. He was, you can see, febrile almost every day in the beginning and then kind of intermittently every other day, but pretty consistent. And also notably, he had pretty high fevers, like up to like 103 most of the time. You can see that his CRP did go down after he got the infliximab, and then he was given methylpred and prednisone at some point, which did, on the bottom graph, you can see causes fevers to go down for a while, although they did recur later in the hospital course. So throughout this whole time, we're talking to the medicine team, and they are keep saying he's fevering, he's fevering. What are we going to do in terms of his dispo? And from our perspective, we thought that one, the fevers aren't necessarily discharge barrier. Fevers in Crohn's disease can take a while to resolve, but also we weren't really sure that these fevers were related to the Crohn's disease. So he was ultimately discharged. As you can see, he was afebrile for several days towards the end, but unfortunately, he continues to fever. And then me and Grant were on call together. And then, funny enough, we were able to see him again. And you can see that during the next hospitalization, his CRP went back up and he was fevering every other day as well. So fevers and Crohn's disease. I'll give it back to Grant for some hot tips about whether this is typical or not.
Absolutely. This fever curve is atypical in Crohn's disease, whether they have active Crohn's disease or not. Typically, in patients with active inflammatory bowel disease, ulcerative colitis, or Crohn's disease, while patients will often have subjective fevers and may have a low-grade fever, it is atypical for it to just be from active inflammation. I've seen it, but it's not common. And that should really make you think, what am I missing here? There are many other things on the differential that will give you high sustained fevers that are not IBD. So that was another piece against Crohn's disease here, this fever curve, including after surgery.
Yeah. So what I learned was that we typically, even if we did have fevers, they would be low grade and they would make us think of an infection or something else rather than coming from the IBD itself. So when he was readmitted, because he was continuing to fever, he got another CT scan that again showed this segment of ileum that could be inflamed near his ileostomy, but also extensive mesenteric lymphadenopathy. And for the first time, the radiologist said concerning for a lymphoproliferative process such as lymphoma, which I think allowed everyone to anchor away or break the anchoring towards Crohn's disease and try to think more broadly about his case. He ends up getting a pet, which I think I can play for you here, but you can also see the still image that he has some lymph nodes that are lighting up in his neck, which were palpable on exam. This lymph node versus mass near his stomach, some liver lesions, and then all this mesenteric lymphadenopathy. And then this radiologist raised the concern this could be Kikuchi Fujimoto disease. Which is a necrotizing lymphadenitis. And what does that mean? So he again gets a lymph node excisional biopsy to look for lymphoma and also try to evaluate for this Kikuchi Fujimoto disease. And we have a wonderful pathologist who can say more about this in just a second. But essentially, my understanding is they thought that because it lacked an inflammatory infiltrate, this could be a self-limited necrotizing lymphadenitis, though other things can appear similar. So this is a rare entity that occurs mostly in young Asian women, although can occur in other people as well. It is typically as tender lymphadenopathy. It can have like fever, fatigue, night sweats, can have leukopenia, which he did have, elevated ESR, CRP. There's no serology that diagnoses this. So it's mostly a pathologic diagnosis and ruling out other things. He did have this absent neutrophils and CD8 positive T cells. And you can see that there is a differential diagnosis, which is like ruling out other infections, ruling out lupus, and then ruling out lymphoma. If this is what he had, you would be mostly supportive care, steroids if really needed, but like the data around this is pretty poor. You can see that it does have mostly cervical lymphadenopathy. Abdominal lymphadenopathy is possible. And if you are a male, which he is, it's typically as you are younger and as you get a bit older, it's mostly in females. Fever is one of the most common symptoms as well. And there was a case report about this in a patient with Crohn's disease that they highlighted the importance of ruling out lymphoma before giving biologics, which we'll talk about in a minute. He ends up having a lot of other infectious workup, as you can see here. His EBV was elevated, but at that point, I didn't know what to make of that exactly. Heme-wise, he had pretty extensive heme workup, thought about HLH, didn't seem consistent with HLH, had a heme sample with some variants of unknown significance, had a bone marrow biopsy and lymph node flow cytometry, which were overall normal, and then all the room labs except for an indeterminate p-ANCA were negative. Here's his flow, which essentially was all normal. And then at this point, he continues to fever. And we have all the consultants all kind of looking at each other. ID's like, well, we've done a pretty extensive infection workup. It's probably not us. Rooms like all our serologies are negative. And heme is also like, it doesn't seem like it's us based off all of these pathology biopsies that we've had. And on the GI side, we're like, we really don't think that this is Crohn's disease, although this is, a potential source of the fever. We're not sure that this is Crohn's, and we need to think more broadly. So you can see everyone's, workup saying, what we said before, that everyone's just signing off. There was heme, I think astutely said, repeat EBV in 1 week. This could be a chronic active T-cell lymphoma. And then also we shouldn't give any more infliximab while lymphoma remains on the differential because there's a black box warning. So just a little bit about that black box warning. There was a JAMA paper that showed that TNF-alpha inhibitors increase the risk of lymphoma, and it's additive if you also have them on thiopurines as well. There was a systematic review on this as well that showed this is true, and then it does carry a black box warning, which you can see here, which is something we should think about before we give people infliximab to make sure that lymphoma is not on the differential. He ends up having another episode of bleeding, hemoglobin 11 to 8. They're actually compressing his ostomy pouch from the outside. And reading the notes, my understanding is that caused vomiting. So they ended up intubating him because of that, because they were trying to hold compression, placed a cordis, MTP'd him. He had a CTA again. With active bleeding from his ileostomy. And then surgery was consulted. They didn't want to do any more surgery due to concern for shortcut. So then he goes again to IR and gets embolized again. So at this point, I know we have about 15 minutes left. Does anyone else have any thoughts about what would your next step be in this case? We've had a lot of biopsies so far that are negative, and it's not really clear where to look next.
How about the gross specimen of the ileocecal resection? I'm interested that that really had, you have a clear tissue there, and I would lean on my expert pathologist to give
Yeah.
some more guidance. I agree too. This does not feel or think like Crohn's. Lymphoma or something lymphoproliferative definitely is much higher in my differential.
Yeah, I agree. So if we look back at the PET, this is the one thing that we never actually poked, which I think it's funny. I was showing this to my wife yesterday, and then like when I first showed her the PET, she's like, "What's that?" and pointed at that. So that's something that we didn't actually see anything on the upper endoscopy. So we went chasing after that. We had Pradeep who did an EGD, EUS, an FNA biopsy, and when he did another EGD, he saw a previously not seen ulcer with averted edges in the fundus, which was biopsied with FNA. They also looked at these liver lesions as well, but they weren't biopsied. And then we finally get the diagnosis based off of this. Any thoughts? So it was ultimately found to be an EBV positive extranodal NK T cell lymphoma, which my understanding is it's positive for its CD3, CD56, and cytotoxic T cell markers, as well as is this EBER stain, which we can talk about in a second. This is the gastric biopsy here. You can see the CD3 positive, gran enzyme positive, perforin positive. And then, interestingly, all the prior biopsies were re-reviewed, and they added these stains plus this EBER stain, which is diagnostic for having EBV RNA in your cytoplasm, is my understanding, although I'll hand it over to a pathologist in just a second. And the lymph node biopsy, the small bowel resection, and the ileoscopy were all positive. So his PCR was positive was in the blood, which was a hint towards this, but really having this EBER ISH is the gold standard. So I'll hand it over to you, Sebastian.
Sure, yeah, we can go back to the images and yeah, so I guess we don't have a good H&E, but that's okay. On the H&E, the lymphoma cells are pretty small to medium. You can see on the left-hand side, the CD3 highlights both T cells and NK cells, but in this case, because it's an extranodal NKT cell lymphoma, a lot of that CD3 is in the NKT cell lymphoma. And you can see that cell in the middle, it's kind of larger, but a lot of these cells are pretty small and they overlap in size with just normal T cells. So on H&E, you can imagine that it was fairly subtle. It was expanding the lamina propria variably in the different specimens. But yeah, the expression of cytotoxic markers, that gets you to either NK or T. Then we have EBV expression, which gets you to either an EBV positive T cell lymphoma or EBV positive NK T cell lymphoma. But ultimately, this all fits best with an extranodal NKT cell lymphoma, and it's pretty rare for it to present in the GI tract initially. Usually these present in the nasopharynx as a nasopharyngeal mass. So this is a pretty unusual case, and the limited case series that I've seen are mostly from investigators in China, where these EBV positive lymphoproliferations are more common, and are more extensively studied, and they have quite a poor prognosis.
Is
Yeah.
it presenting with like acute bleeding in the nasopharyngeal area too, like with ulcers in those cases? I was curious.
In those cases, it typically doesn't present necessarily with bleeding. From my experience, it usually presents with maybe the patient has rhinosinusitis or sinus pain, or but yeah, bleeding is not a feature that I'm aware of that's common.
Can I ask, I mean, I think that from like a medicine GI perspective, often we think of like pathology as like the gold standard and like whatever pathology said is, that there's, either lymphoma or not lymphoma. I think that like in our emails you were saying we could consider adding this like EBER on. When do you think that we should do that? Or like when do you think we need to like request additional, studies, for instance?
Yeah, I think, this is obviously a very challenging case, and hopefully everybody in the audience remembers this for maybe when they see this in 20 years, because it's going to be a rare presentation. But particularly when the EBV was positive in the plasma, I think it would have been very astute for somebody to say, oh, let's go back and ask the pathologist to stain for EBV on the tissue specimens. I mean, that's obviously asking a fair amount, um, but I think that would have been a way to pick this up earlier, perhaps. Um, I've seen a case of chronic sinusitis that was signed out as chronic sinusitis, and we get those specimens in surgical pathology all the time. Chronic sinusitis is very common. And then a year later, the patient has a diagnosis of external NKT cell lymphoma nasal type, and then they go back and do an EBER stain on that chronic sinusitis, and it lit up a lot of the cells. So, I mean, it's really kind of a sneaky, treacherous lymphoma in a lot of these specimens.
Thanks so much. It's really helpful. So what I know about this is like we were saying, there's a nasal subtype and there's a non-nasal subtype where 80% of people have the nasal subtype, 15 to 20% of people have the non-nasal, which can affect like the GI, skin, testes, and it can mimic Crohn's disease. And the diagnosis is really biopsy with this ER-ISH, and the DNA can guide prognosis. It is mostly East Asia, although there is a Latin American predominance or a Latin American association, which this patient was from Latin America. A note, kind of, we've talked about starting biologics in IBD. The infliximab was probably started too early in this case at the outside hospital with weak evidence of Crohn's, but as we all know, it's hard to stop these things once they're started because there's concern for drug antibody risk. So just another, highlight to say that it's important to confirm the diagnosis of IBD before we start biologics, and it's safer to just give patients steroids since there's not this concern with those. Comparing the nasal type and the non-nasal type, there's a lot of words, but essentially you can see, like we were saying before, the nasal type is mostly epistaxis and a nasal obstruction versus the non-nasal type can mimic Crohn's or IBD and can cause perforation, which we did see in this case because it is a transmural ulcerating mass, which has necrosis in the GI tract. And then again, it does have a worse survival, particularly because patients often present at a more advanced stage and relapse is frequent. There is actually a pretty decent case report a series on having EBV-associated lymphoma mimicking IBD for this reason, that it can cause bleeding. It can just look like IBD, especially because, or I'll get to that in a second, I guess. Patients can have intermittent fever, hepatosplenomegaly, lymphadenopathy. You have higher EBV viral loads. 40 to 70% of patients have hematochezia, which can be fatal, has a median survival of 21 months, mostly from hemorrhage, perforation, DIC, or can cause HLH on its own. So should think about this when we have Crohn's-like ulcers with fever not responding to standard therapy or have EBV quantification. And it's a reason to think about adding on the EBER stain, which will help avoid unnecessary immunosuppression. There was a study just on radiographic findings and endoscopic findings. You can see the ileocecal area is the most common site, and then the stomach, which interestingly is both the sites that we saw with him. And then you can have various patterns of ulcerative infiltrative lesions, ill-defined ulcers, deep solitary ulcers, multiple erosions, or just nodular mucosa. And there was another CT series that they looked at the CT findings of all of this, and I thought that it was interesting that absence of lymphadenopathy they reported is typical. More than 75% of patients don't have extensive lymphadenopathy. So this is maybe one of the, it's a little bit atypical that he had so much lymphadenopathy, is my understanding, and that it's often misdiagnosed on CT, which only 25% call lymphoma. Although I think it's a high bar to call lymphoma on initial CT. He ends up getting chemotherapy, and then had another episode of hemorrhagic shock, went to the ICU, was scoped by Helen and Sid and needed another IR embolization, but then didn't bleed for several days and was ultimately discharged. You can see that his EBV went down over time and is now detected, but less than 100. And he recently saw onc as an outpatient. And I thought, interestingly, they say the goal is curative. And there are high response rates, and it does seem like he is someone who is responding. I think there's another subset of people that are just primary non-responders, but despite his response, he is overall high risk based off his high titers, and his overall 3-year overall survival is low. So my takeaways are that high fevers and profuse bleeding are atypical of Crohn's and should cause all of us to think about something else. Infliximab is contraindicated in lymphoma, so caution if this is on the differential. And that path is often a gold standard, but has its limitations, and you have to think about sending EBER in this particular case. As GI doctors, this is something that we're probably going to be the ones seeing. So it's good for us to know about this extra stain. And that's all I have. I have some references, and I'd like to thank Grant and Sebastian for being here and providing some extra insights in the case.
Thank you so much. That was a really impressive case and discussion. Appreciate all the expertise involved in that. Question for Sebastian about like the initial biopsies endoscopically of the ulcers. When we normally look for like it's common to look for CMV when we think of anybody for IBD, but other than the EBER specific, is there anything for EBV that could have led to a different plan or course?
Morphologically, there isn't necessarily like an inclusion that you see like for CMV on the H&E that would give you a clue that you need to do the EBV stain. Is that kind of your question?
Yeah, or should we just ask like if we're scoping them again, or he had multiple probably endoscopic evaluation biopsies requesting that additional stain early on versus the EBER specific.
Yeah, obviously, I mean, the differential diagnosis was still extremely broad, even when the diagnosis of IBD was kind of questionable. So it's hard to say, oh, you definitely should have done an EBV or EBER stain among all the things that you would consider. Obviously, given that we're talking about this case, it's clearly a good idea to think about. But yeah, I think once the EBV was positive on the PCR, obviously ID thought it was, of uncertain significance, but I think putting ID in touch with PATH or, saying, can you do an EBV stain on some of these biopsies, that obviously would have helped accelerate the diagnosis. Yeah.
Got it. And lastly, was the gross specimen, like impressively, he had the whole ileocecal resection with so much bowel removed. Was there anything earlier that would have changed our course, or we should have looked for?
Yeah, I also wonder if the perforated appendix, we don't have that specimen here, but it would be interesting to know if that had EBV positive NKT cell lymphoma. I suspect there's a good chance that it did. Yeah.
Thank you. That definitely took a whole team effort to diagnose. I'm glad it sounds like it can be potentially curative too, and hopefully no more acute bleeding like this.
Thanks, everyone.
Thank you, Josh. Thank you, Sebastian and Grant.
Thanks, Sebastian.
Great presentation, Josh. Bye.
Hello,
Hey, Samer.
how we doing?
We're all great. The floor is all yours.
All right, I guess we're ready. Hi, everyone. Today is the GI M&M conference. And before I start presenting the case, just a few reminder about, the purpose of this conference. The M&M conference fosters a climate of openness and discussion about adverse events, medical errors, near misses, miscommunications to identify areas of improvement. The M&M is a forum of constructive criticism to profit from sharing and examining our experiences in a blame or shame-free environment. And this is conform with the publication by the Institute of Medicine that came out in 2000, titled "To Err is Human." And they quoted, or they said, I'm quoting them here, the problem is not bad people in healthcare. It is that good people are working in bad systems that need to be made safer. So most of the time, it's really identifying the problem in the system that needs to be fixed in order to prevent an adverse event or a mishap happening in the future. And it's important to note that our discussions at the M&M conference are confidential and should not be discussed outside this forum. So before in this M&M, it's going to be a little bit different. I'm going to present the case, but the focus is not, at the end, is not going to be on the case. It's going to be, the focus is going to be on delivering bad news to the patients and the impact of adverse events on the physician who faces these adverse events. I don't think these are things that we've been highlighting in the past, but I think it's worth going over it because every one of us had this experience before. So this is a 76-year-old female with history of Whipple surgery for well-differentiated pancreatic neuroendocrine tumor that she had in 2010. Patient had many ERCPs for stones retained at the level of the choledochorial anastomosis. In 2022, she had a biliary stent placed due to difficulty extracting the stone, but it was subsequently successfully removed based on the report from the outside institution. Her last ERCP was in June of 2023 when ERCP was done with removal of few small stones and anastomosis was widely patent, so they didn't have to dilate the anastomosis. There was no evidence of a stricture at that level. All the above care was performed at UT Southwestern in Dallas. In December of 2023, while visiting her family in California, she started having shaken chills and abdominal pain, along with nausea and vomiting. Symptoms felt exactly similar to her previous episodes when she had problems with stones. So she presented here to the emergency department where the liver enzymes were elevated, and the CT showed the 12 by 13 millimeter lesion at the choledochorial anastomosis with upstream dilation. So what was shown on CT here, this is the choledochal, the remnant of the bile duct leading to the intrahepatic biliary tree. The CT could not differentiate if this is a soft tissue versus a stone, but it looks like there is a blockage. Most likely, it's a retained stone that she's been dealing with for years. And as you can see here, the stone is obstructing the biliary tree. So patient was admitted to the hospital. She was started on IV antibiotics. Blood cultures came back positive for Klebsiella. And within a few hours, her abdominal pain and nausea and vomiting have resolved. So this is what we're dealing with after Whipple surgery. We have altered anatomy here, and the ERCP is really challenging in these patients due to that. So what we need to do in these cases is to go through the stomach into the pancreaticobiliary limb in order to reach the choledochorial anastomosis. A lot of times there could be a stricture here that needs to be dilated, and in this case, going after the stone that was retained in this remnant of the extrahepatic bile duct. Here you can see the pancreaticojejunostomy into the pancreaticobiliary limb. So we performed the ERCP in this altered anatomy. We used a single channel therapeutic scope. We were able to get to the choledochogenostomy, and which we dilated during the procedure. And we were able to see through the opening, we were able to see the large stone inside the duct. We performed lithotripsy through the single channel scope, trying to fragment the stone. We were able to partially fragment the stone and get some of the fragments out. It took a lot of time in order to really perform this procedure. And at the end, we were able to, you can see here the stone, we're able to get some of the fragments out, but not completely the stone. You can see here when you peek into the biliary tree, you can see the bifurcation with the right and left main duct. And once you enter here, even with the cholangioscope, you can see the stone, as the stone is here in a pocket next to the anastomosis. It was really challenging to kind of get it, along the axis of the lithotripter, the EHL, in order to break it, and also along the axis of the balloon in order to get it out. But we were able to partially fragment it, get some of the fragments out, and then we concluded the procedure. And the plan was to really come back in maybe a few weeks to try to repeat the procedure and try to get the rest of the stone out. You can see here the ERCP and the short segment of the stone. When we inflate the balloon and try to get the stone out, the stone goes here into like an outpouching next to the anastomosis, and it was very hard to get it out. Here you can see some of the fragments coming out. So the patient did not, she went back she felt great. She went back to Texas, and then she returned to visit. And during her visit, we saw her in clinic in September 2024. She was doing well, no abdominal pain, no back pain, no nausea, vomiting. LFTs were normal. And she elected not to pursue a repeat procedure. And then we haven't heard from her until June of 2025, when she came to visit California again. And she requested an urgent clinic visit. During the visit, she reported that she had an episode of fever, chills, along with fatigue and back pain a few days prior to the clinic visit. She went to the ER then, and CT showed changes in the peritoneum, with stranding in the peritoneum and possibly persistent stone in the biliary tree. Her LFTs were elevated during the ER visit, and she was started on antibiotic and was sent home. In the clinic, she reported that she feels better with resolved fever and back pain. So we repeated the liver function test, and we reordered the MRCP after the visit. You can see here the MRCP, you can see the stone is still, intermittently blocking the biliary tree. And here it's probably about 8 millimeters. So it's smaller than the 13 millimeter from before, but it's still there and causing problems. The LFTs that we repeated showed that her LFTs are coming down. The bilirubin remained normal during her visit to the ER and later on. So we discussed with her that we need to, since she had these episodes and recurrent episode of obstruction, biliary obstruction, and cholangitis from the stone, we tried to attempt to repeat the ERCP again. So she agreed. We brought her for the procedure. We used, like we did during the previous procedure, we used the single channel scope and tried to go into the pancreaticobiliary limb. And despite, all the maneuvers tried to get through to reach the choledochogenostomy, we were not able to do that despite, applying abdominal pressure and changing patient position. So that was not possible. We changed the scope to a pediatric colonoscope to see if that will help, and we faced the same issue. Now, while pushing the pediatric colonoscope, trying to reach, going around, trying to reach the choledochogenostomy, I felt, while pushing, I felt a pop. So I immediately pulled the scope out, and once I reached the area here, just distal to the gastroduodenostomy, I see this, view on endoscopy. So as you can see, I mean, it was like for a second I saw it and then, suctioned and, tried to process what I saw. Um, then, when you see something like this, you try to say, well, that didn't happen. But then you saw something that you have to go back and take a look. So I insufflated again and took a look, and this is what I saw. So this is not a great scene that you can see during endoscopy. You can see here the fat, and you can also see some blood and the external wall, the outside wall of the colon. So this is a perforation, a large perforation that happened at this level here, just distal to the anastomosis, while pushing the scope. So the side of the scope, like the shaft of the scope, was putting a lot of pressure on this fixed segment and caused this perforation. So immediately we decompressed the stomach. We placed an NG tube to suction, started on IV antibiotic, and called the surgeon for emergency surgery. We called the surgeon. The surgeon said, you're gonna send the patient to the ICU and then we'll come and evaluate her and do surgery. We said, no, we prefer that you come right away. We're gonna keep the patient intubated and you perform surgery right away. So the surgeons came over, evaluated the patient in the room, and then started the surgery. And after we stabilized, the patient, we had to go and do the most difficult part of this whole process is to talk to the family, or one of the difficult part of this process, talk to the family and update them about the event. So I went and spoke to the daughter and told her exactly what happened. The patient had surgery, revision gastroenterostomy with small bowel resection, and they evaluated the abdomen. There was a lot of adhesions, and the omentum did look like disease to them, so they took a resection of it and sent it to pathology, and they removed some of the mesh and the metal tacks during the surgery. So the surgery was very complex. We had a colorectal surgeon involved and the minimally invasive surgeon involved, and we had also an open communication with pancreatic biliary surgery. So when facing, adverse event like this, we have the tendency to deny and defend. And this is really not a great and conducive strategy. A more patient-centered approach that emphasized early acknowledgement that the adverse event happened. So a quick action takes place. And then as soon as possible, disclosure of adverse events, to the patient or to the family members is a more proactive method of achieving a fair resolution for the patient, family, and involved healthcare providers. So who needs to disclose the information or the adverse event to the family? Preferably the physician involved in the event. And if the physician is not available, like if physician isn't still involved in taking care of the patient, stabilizing the patient, then one of the team member should go and disclose the information to the patient. What need to be disclosed are only factual information. There shouldn't be any speculation. If you don't have full idea what happened, you just tell the patient that once we have more information, we will be updating you. When to do that, when to disclose these informations as soon as possible, as soon as you can, as soon as you stabilize the patient, go and disclose these informations to the family. Where to do so? Of course, like making sure that all these information are given to the family in a confidential way, in a quiet and a separate room, comfortable to the family members and to the patient if the patient is still there. How, it's important when delivering these information to make sure that, the conversation include empathy for what patients and their families have experienced. Usually like trying to make an open statement. I mean, that there has been like an unanticipated event, and I'm here to tell you everything I can. You have to sometimes, stop and just let them process the information, allow some silence, and explore the emotions. Let them process the information. Then, assess understanding. A lot of times, during this case, the daughter kept asking after I explained, what happened to her. She kept on asking, what happened and how did it happen, and why did that happen? What's going to happen to her mother after the surgery? I mean, we told her what happened during the procedure. We told her that we're gonna, do our best to repair, the perforation. The surgeons are working their best to do so. She said how she's gonna do after that. We told her like, it all will depend on what's gonna happen during surgery, and then we're gonna monitor her closely after the surgery and make sure that she receiving all the treatment that she needs, and we're hoping that she will do well with that. It's okay to allow yourself to be vulnerable, because that will show sincerity, and it's okay to offer words of apology, like I'm sorry this happened. But apology does not mean that you are accepting blame. You have to avoid blame. Be careful not to prematurely assign blame with phrases like "we screwed up," "this is our fault," or "this is the fault of one of the staff." Subsequent conversations after additional investigation will better address this. This is really important to distinguish between these two things. Then, if needed, supporting the patient with spiritual and emotional, providing spiritual and emotional support, inviting a behavioral health provider or a clergy to the meeting, or offer to facilitate services after that. Financial support that will, is usually done by the organization, especially if these are raised by the family and the family members, so involving, staff from the organization to deal with that. But this is something that usually happens later on, not in an acute phase. In California, and the reason I mentioned there's difference between apology and blame. In California, there's a medical apology law, and this is something that's important to know about. And what it is, it's a law that protects expressions of sympathy, regret, or benevolence made by healthcare providers to patients or their families after an adverse event. It states that these expressions shall not be used or admitted into evidence in any civil, so they're inadmissible. In any civil action, they can't be used. And the protection does not extend to admissions of fault or negligence. That's why it's important not to really assume blame. For example, a statement admitting I made an unavoidable mistake should be avoided, even in the presence of an expression of sympathy. The purpose of this is to encourage doctors to apologize and communicate openly with patients without the fear that their words will be used against them in a lawsuit. So, this is during, delivering adverse events and bad news to patients. But all of these like events and have really an impact on healthcare workers, and many of healthcare workers suffer life-altering burdens of anxiety, depression, and shame after adverse events outcome. And so this was called in a publication by one of the physician in 2000 as second victim syndrome. And this second victim syndrome is not, it has a spectrum of severity. It can be, you know, mild. The physician will recover quickly from it to severe, causing depression, you know, suicidal ideation, and lead to suicide. So it is an important, you know, thing to know about and to really be able to identify if seen, and to deal with accordingly. So most of the providers have experienced this, you know, in a way or another, this syndrome with different, you know, severity at one point in their career, and it really carries emotional ramifications for those who witness those. As expected, you know, folks who have subspecialties that could be associated with catastrophic patient events like emergency medicine, surgery, and intensive care intensivists have increased SVS, second victim syndrome, and their attendant psychological ramifications. In one of the surveys, 25% of emergency physicians and 25% of emergency nurses, 22% of ICU nurses, residents, and 15% of trauma surgeons and 17% of anesthesiologists report extreme and pervasive distress from, you know, getting, you know, witnessing, you know, these or experiencing these adverse events. These can, if they remain attended with that severity, they can lead to really, you know, PTSD. They can lead to depression and can lead also to suicide. So what's the natural history of recovery for the healthcare provider as a second victim after an adverse event? So initially you go into this like chaos and accident response. You try to control your emotions in order to take care of the patient. So you don't have time really to reflect much. You're trying to take care of the patient. Then, you know, after that, once the patient stabilizes, you start having these intrusive reflections. You know, the provider worries, ruminates, and starts replaying the incidents. Could be for days, for weeks, for months, or even sometimes years. This can interfere with providers' personal and professional lives, and it's important to really identify those. And once it's interfering with personal and professional life, it's important to recognize that and then seek medical attention. Fear of rejection versus seeking confirmation. This is something that will happen. Usually, providers worries about, you know, others' perceptions of what happened, and that others may doubt their competence. So sometimes they also seek confirmation, talking to colleagues about, you know, what happened, trying to get, you know, some positive support, saying that this is something that, you know, usually can happen, and you have to kind of move on. And during the acquisition, it takes time usually. I mean, if the case is being investigated or the incident is being investigated, peer review or quality improvement review, or from a licensing board investigation or lawsuits, it takes usually months, and sometimes in lawsuits it can take years. So providers, you know, during this period of time, I mean, they are really under a lot of stress and anxiety. Emotional first aid, you know, providers connect with colleague, you know, to seek help. Talking to a colleague is helpful. Talking to a mentor is helpful. And in some cases, you know, if it's really affecting their you know, lives, seeking assistance from mental health professionals. The ultimate outcome, you know, I mean, some people, as a result of this, I mean, depend on severity of the second victim syndrome, may drop out. Some people will survive and live along with you know, just keep like ruminating about it, or thrive after the event, just move on and learn from, you know, the adverse event, and just, you know, keep taking care of patient and helping other patients, and forgetting about that event. What can happen from these? I mean, the symptoms or this is from a systematic review that included these studies. 11, almost 11,000 healthcare providers suffering from second victim syndrome, troubling memories, anxiety, anger, regret, distress, fear, embarrassment, guilt, and sleeping difficulty. A high percentage of these symptoms can happen in folks suffering from this syndrome. But as I mentioned before, the most concerning of all is severe or long-lasting symptoms that might lead to severe depression and suicide. Among surgeons, those who consider suicide are more than 3 times more likely to report a self-perceived medical error in the prior 3 months. So it is really important to really identify these, identify folks who are suffering from this syndrome and see if they need to seek mental health help. So, what helps recovery? I mean, this is a study that examined aspects that influence psychological impact on recovery of patients, safety, incident on physicians, nurses, and midwives. This is the retrospective surveys of physicians, midwives, and nurses in 33 Belgian hospitals, about 913 healthcare workers who were involved in patient safety incident. So they retrospectively measured the psychological impact of the safety incident at the time of the event and compared that to a survey for the psychological impact at the time of the survey itself. So there's a lapse of time between the event itself and the time of the survey. So what they found is that the psychological impact is higher when the degree of harm for the patient is more severe. If the harm was treated with death, then usually the impact is as expected is higher. When the professional feel responsible for the incident, and also higher among female healthcare professionals than male ones. Impact of degree of harm differed across clinicians. So folks, physicians' response to these varies from one person to another. The psychological impact based on the surveys that they had is lower among more optimistic professionals. Overall impact decreased significantly over time. So people forget. So get busy, keep doing cases, help other patients, and that really help them forget. The other important thing is support culture by the organization reduce psychological impact, whereas a blame culture increases psychological impact. So it's very important that the organization follow this approach. So the conclusion from that study is that healthcare organizations should anticipate on providing their staff appropriate and timely support structures that are tailored to the healthcare professional involved in the incident and to the specific situation of the incident itself. What's important is that from that survey that employee perception of support was very helpful. So this support by organization was the most important factor in ameliorating symptoms of second victim syndrome. So here at Stanford, we have the program. It's physician peer support program. They have an email that to which you can contact them, and they usually respond, touching base. The information is confidential and it won't be disclosed to anybody else. There's also a website, wellmdstanford.edu, that also has information about the support for physicians who need seek that. So this is the email, and this is the site. Now, for going back to our patient, the resection of the omentum showed that it is involved with high-grade serous carcinoma of ovarian origin. So, I mean, when I was asked after the procedure, or was asking myself after the procedure, what was different between this one and the previous one, this could be the difference. I mean, it's more like, the patient has carcinomatosis, more adhesions, that's leading to more fixed bowels and more pressure by the scope by the side of the scope on the wall of the bowel. The patient, did well, after this, this event and this surgery, and she was discharged home after 6 days and had a later follow-up with oncology. It was really, really I mean, kudos to our surgeons, really, because the surgery was very difficult surgery with all these adhesions that she had, and on top of that, carcinomatosis, and trying to figure out a way of reconnecting the bowels was really a challenge. So the collaboration between our surgeons at Tri-Valley and also our pancreatic biliary surgeons at Maine, yeah, some of the collaboration was virtual, was really helpful to save this patient. So this is really just highlighting the importance of really disclosing, these unpleasant news to family members. It's something that we have to really face. We cannot really escape from it. It's important to really do it as soon as possible. It's important to show empathy. It's important to apologize, but at the same time, not adopt blame. It's important to give the information that you have in hand and not speculate, and tell the patient that we will update you once we have more information. It's important also for us and for physicians to seek help if needed, if they feel like they are suffering from the ramification of the adverse event. Talk to colleagues, senior colleagues, talk to mentors, and if needed, seek mental health assessment. It's important also for us to really identify any of our colleagues who might be suffering from that, and especially if there is a big event where you expect that they might be affected by this. It's also important that our organization is really acknowledging this, and that we have support provided in case we're facing situations like that. Thank you. You guys still awake?
I think Summer didn't know that there was a nice supportive law in place in California for us to encourage.
Yeah, I was surprised. It's important.
Summer, I have a question. Was it like a pancreatic osseous carcinoma? I just missed that part. Like, is it like the metastatic like omentum was from pancreas?
No, so she had the previous history of neuroendocrine tumor and surgery in 2010. This one is of ovarian origin. So this is a new tumor. Did I answer your question, Amir?
Yes, you did. I was just wondering, was it like anything that was missed in the pancreas, but it was ovarian, like then nothing
Yeah.
to do with
Well,
like,
yeah, 15 years prior to that, she had the surgery for a completely different tumor. And this time, I mean, her CT scan have shown that there are changes in the omentum, but didn't show any mass in the ovaries. And then when they opened, after the perforation, I mean, they found that it looks a little bit, not a healthy area. So they sent it for pathology and it came back positive.
Sarah, thanks for sharing that case and providing some of the resources. I was just going to say that in the IBD practice, sometimes we know people for decades, and we watch them, take care of them through phases of life. And sometimes I feel that it's almost like you cross this line where you have this personal caring for the person, and you're doing stricter procedures, and you feel this level of worry about a complication or taking care of them, as though they were almost like a friend or a family member. I don't know if other people have experienced that, but I feel a difference, and I have to kind of guard against that. I'm not sure, on the one hand, I guess it's because we care, and we don't just care about them as a patient we're taking care of, but I think it also makes it harder sometimes.
Yes, it is hard. It's, with this patient, after the first procedure, and the fact that we told her that, part of the stone was not removed, she felt a little bit difference between our care and, the care at the other facility. And she came back to see us, and she wanted the procedure to be done with us. So you kind of, like establish this kind of relationship with your patient, especially if they put the trust in you. And then, something like this happens, it's kind of, you feel like you disappointed your patient. And then, going out and talking to a family member and, the daughter, I mean, you trying to suppress your emotions in order to take care of the patient, and also in order to talk to the family while they are, all the emotions are heightened. You're talking to the daughter, and she is really very emotional, asking, is my mom gonna die? Is my mom? So it is an issue. When you establish this relationship, it's hard. And especially if it becomes like, that's why you can't take care of a family member. So it's just very difficult. Even if it's a simple colonoscopy. I had one of our friends, he insisted on me doing his colonoscopy. And even with that, I was a little bit, I'm never nervous doing a colonoscopy, but I was a little bit concerned about him. Concerned about him having, issues with sedation, something happens. So that's why I don't think it's recommended for us to really befriend, not be like socialize, I would say. I mean, you become like, you have a special relationship with your patients, but you can't socialize with your patient. You can't take care of family members for that specific reason you mentioned. Do you guys know about this California law? Yeah.
No, that was a good thing to know and share with us. Thank you again.
Anybody else? Very good. Thank you.
Thanks, Samer.
Thank you so much.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University.